I'm Dr. Raj Dave from Harrisburg, Pennsylvania, and I welcome you to join this very exciting webcast, Academy Live from Interventional Academy and C3 Studios in Harrisburg. First, I want to wish everyone Happy New Year. Today, my guest will be Dr. George Vetrovec, who is Professor Emeritus of Medicine at Virginia Commonwealth University in Richmond, Virginia. Today's subject will be Cardiology Year in Review 2019 edition, and what an exciting year it has been for new clinical trial science. So we have a lot of ground to cover, so without further ado, let's get started. So George, first let's tackle PCI in stable CED. You know, this has been an issue of controversy for several years. Several years ago, the results of the COURAGE trial came that has been a sensation in the media. Now the results of the ischemia trials have been just presented, and that's been a sensation in the media as well. So let's address this first. Could you talk to us about the results of the ischemia trial and the trial design, so
Sure.
we can then discuss it?
Yeah, it's an important trial. It addresses an important concept. The concept is are patients who have significant ischemia at greater risk with medical therapy versus compared to revascularization, and that was the principle of the ischemia trial. The nuts and bolts are a little bit different in that the patient population was limited to exclude patients with left main and to exclude patients with markedly reduced left ventricular function and to exclude patients who had such frequent angina that it wasn't just possible to randomize them. But once you had that group of patients, they randomized approximately 5,000 patients internationally to either a optimal medical therapy or to revascularization, and followed them. And the hard results of the trial were there were no significant difference in overall endpoints favoring either treatment. So medical management is acceptable. Now, a couple little caveats, and one of the caveats is that when one looks at the risk of subsequent myocardial infarction, the risk was initially a little higher in the PCI group, but over 2 years the lines crossed and there was a benefit in terms of less myocardial infarction. The authors appropriately say this is equipoise, but I think we need to look forward to ACC 2020 because they're going to actually present the MI sub-study. And the question is are the initial MIs tiny peri-procedure MIs or are they serious MIs?
Yeah, we're going to talk a lot about peri-procedural MI further into this discussion. But as you said, the left main was excluded. So the way the trial excluded left main is by doing coronary CTA in about 2/3 of the patients and looking at the left main disease and excluding these patients. So that's very important that for a clinician who sees a patient with stable coronary artery disease, that they need to make sure that the patient doesn't have left main disease. So if you take a sample of the whole of our country, you know, coronary CTA is still in its early phases of adoption, you know, countrywide. You know, in my center, you know, we do coronary CTA, but in a few patients. But majority of the time, if there is a question about whether the patient has left main disease, we would do a cardiac cath. So do you think that this is going to change the practice on how we screen for CED?
Well, I think that's going to be a great debate. I still think there's a role for exercise testing, particularly because there's something that you learn from knowing the functional status of a patient, and there's something that you learn from how their perfusion is and so forth. So I don't think stress testing is gone. I think CTA has some roles, but I'm concerned because some patients have heavy calcification, makes it very difficult to read. And frankly, some centers don't have the same experience at reading the studies. So I think coronary angiography is still the gold standard and will continue to be used. Now, adding the non-invasive FFR to the CT scan clearly has helped improve it. But overall, I think one has to be careful that the high-quality CT angiograms are available too. But the idea of knowing heart function and whether or not a patient has left main is important rather than just treating them with medications.
Yeah, I think that you raised a very important issue. However, this issue was not addressed in the ischemia trial, is to have an availability of now FFR value. So let's just say we do a CT FFR and someone has proximal LAD with a CT FFR of 0.7 and a moderate to severe atrial ischemia, but supposedly infrequent angina. What should be the recommendation?
That's very interesting, and I've seen some polls around where people have looked at it, and of course you get different answers. But in general, I think physicians still would probably favor stenting that in the lack of specific evidence about that lesion and that area of the myocardium at risk.
So the physiology would help you,
right,
in a situation like this. Okay, let's keep moving on. The other thing that I wanted to talk to you about ischemia trial was there were two things about quality of life measures that were measured and the angina frequency. And this is where there was a clear-cut difference between medical therapy and invasive arm.
Certainly for the patients who had the most severe angina, there was no doubt there was a benefit for revascularization.
Right.
And that was very clear in the quality of life.
Right. So I think that it's important for, one of the interviews that I watched where on AHA, Dr. Judith Hochman, who is a PI for the study, said the two main factors patient care about is if they want to live longer and they want to feel better. So I guess I cannot agree more than that, more. And clearly, the angina was so much better with invasive therapy, and the patient needs to be educated because there are going to be young patient who is working, and they might favor less angina.
Yeah, a couple of quick things too. Remember, the principle of this study was to see if eliminating ischemia made a difference. And the fact is that we don't know yet how effectively the ischemia was eliminated. That's still being analyzed. But it will be interesting to see if there's a difference between patients who have complete revascularization and patients who did not in terms of the impact in terms of late outcomes. So I think that's still hanging out there. And I think everyone agrees with the MI that this needs long-term follow-up up to 10 years.
Right. What about adherence to optimal medical therapy? This is a big challenge, right?
It's a terrible
in fact, today
challenge.
I did a case this morning, a patient who had stable CED, large amount of ischemia, physiologically significant coronary disease, had intervention a month ago. I had recommended several different treatments, including PCSK9 inhibitors because he had very high LDLs. And he came today for a vascular intervention, and we looked at his labs and his medical therapy. The patient's not started half of the things that we wanted him to start. So this is, I don't doubt it that the optimal medical therapy is a great thing, but only 40% of patients in the study actually achieved it. So in real life, this is a problem.
It's a real problem, and in a study, they make extra efforts to achieve good medical therapy, and I think that's an opportunity that is probably not the same in real practice. There's side effects to medications, there's just patient compliance, there are costs, there are a variety of things that come into play, and just following it. I mean, I don't know about you, but if I've had to take medications, I tend to forget them at times and so forth. So it's a real challenge. So I think that's another issue, and depending upon the patient, compliance of the patient, that may actually help decide what to do.
Right. The last thing that I wanted to mention regarding ischemia trial was the completeness of revascularization and PCI optimization. So I think there were certain centers who does PCI optimization in the study, and then there are others who does a conventional way. And would have an impact on an invasive strategy?
Yes, I think so, and that was what I got to. Completeness of revascularization is important, but in addition to that, you've got to do a good job at the lesion so that it remains patent. And so when you use the term optimization, just in case anyone's confused about it, it really requires either doing IVUS or OCT, intravascular imaging to see the quality of the lesion treatment, post-treatment, or using FFR post-treatment. And the studies have shown repeatedly that using these technologies make a difference in terms of long-term outcome. The patients who have better results do better. And so I think this is very important, and we don't know all of that from the study, and I think that's an important limit yet in terms of our understanding it.
Okay, so my take-home messages from a ischemia trial are: deferral of PCI in select patients with stable coronary artery disease is safe, provided ejection fraction is normal and they do not have left main disease. Very important to have shared decision-making with the patient. Understanding their preference will be critical in deciding invasive versus medical therapy, as we were discussing symptomatic relief and other factors that might influence your decision. And third thing is that adherence to optimal medical therapy is crucial to the long-term outcome of these patients. All right, so let's move now on to culprit lesion versus complete revascularization in patients presenting with STEMI and non-STEMI with multivessel disease. Previously, many small trials, including PRAMI, culprit, compare acute, have shown benefit of complete revascularization in patients with STEMI and multivessel disease. Complete was the trial that was presented last year, is the largest trial to date evaluating the benefit of complete revascularization versus culprit lesion-only revascularization. In addition, the investigators of the complete trial attempted to evaluate the timing of the non-culprit lesion revascularization, which I think is very important, at least in US. Complete enrolled about 4,500 approximate patients with STEMI and multivessel disease. They were randomized to either staged non-culprit lesion PCI versus culprit lesion PCI only. There was further stratification based on investigator choice of non-culprit lesion PCI at the time of the index procedure and the hospitalization, or in a staged fashion. They also did a landmark analysis performed within 45 days and after 45 days, and total duration of the follow-up was 3 years. So what did we find? Primary endpoint of death and myocardial infarction occurred in 7.8% in the complete revascularization group versus 10.5% in culprit-only group at 3 years, a total of 37% reduction. Secondary outcome of cardiovascular death, MI, and urgent revascularization occurred in 8.9% for complete versus 16.7% for culprit only, almost a 58 to 60% reduction in the risk. There was no interaction for non-culprit PCI, whether in the index hospitalization or a stage later on. This large study demonstrated benefit of cardiovascular death and MI in addition to reduction in urgent revascularization as shown in prior study. There are some important observations. In this study, complete revascularization was achieved in over 90% of patients in non-culprit complete revascularization arm. The main driver of primary endpoint benefit was reduction in recent MI by 32%. Kaplan-Meier survival plots, start to diverge very early on in the study, but continue to diverge further as time elapsed in the follow-up all the way to 5 years. This is important in a sense that benefit continues to accrue at a late follow-up. On the heels of this, more recently in JACC, a 5-year follow-up of culprit trial was also published. This is a very small study in comparison to complete, but this study enrolled 296 patients in 7 UK centers and also compared complete versus culprit-only strategy. They reported 40% lower rate of primary composite endpoint of death, recurrent MI, heart failure, and ischemia-driven target vessel revascularization after almost 6 years of median follow-up in the complete revascularization arm. This is a large benefit. Hard clinical endpoints of all-cause death and MI benefit was observed as well. The landmark analysis showed that majority of the benefit from complete revascularization occurred within the first 12 months. This difference observed at 12 months sustained all the way to median of 5.6 years in follow-up. There was no interaction whether complete revascularization was achieved during the index procedure or stage. So what have we learned? In patients with STEMI and multivessel disease, complete revascularization should be the goal. In complete study, the non-culprit lesion had to be at least 75% or FFR less than 0.80. In other words, attempt was made to give complete and optimal revascularization was done. So George, what are your thoughts on should clinician use physiology or image guided therapy when they evaluate a non-culprit lesion after they've already done culprit revascularization in STEMI?
I think using FFR is preferable to visual. There are some issues at times with visual. If it's not available, then I think using a realistic cutoff like 75% is better. One of the concerns is that if you stent lesions that don't need it, you may be setting up a circumstance where they're at risk for late restenosis and so forth that wasn't necessary to improve the patient. So I think it's very important to have the best data you can about significant lesions.
Now let's talk about the timing of non-culprit revascularization, and complete trial addressed this, and also this was followed in the culprit trial, 5-year data, small number of patients, but in complete there was no interaction when the non-culprit revascularization was done. So I think this is one of the issues that come up all the time. I hear about it, that okay, we did the culprit vessel. There are 2 other arteries which are significant disease. When should you evaluate them, and when would you do them? So what are your thoughts on that?
Well, I think evaluating them at the time is helpful because at least you know what needs to be done. The second thing is I think the timing depends on the circumstances. If the patient is restless, tired, it's taken a long time, there's a lot of contrast, it clearly needs to be staged. If the initial procedure was very straightforward, the second lesion looks very straightforward, there is the patient convenience and advantage of going ahead and fixing it at that time. But I think it has to be a judgment decision. It's not one size fits all.
Right. The comforting thing is that in complete, there was no increase in the risk of bleeding, and there was no increase in the risk of renal failure from contrast exposure due to complete revascularization. So that's helpful for the clinician that, if you do it in the same hospitalization or even in the same setting, that doesn't necessarily increase your risk of the procedure or the risk of kidney failure. So George, let's talk about non-STEMI. Because the data for STEMI and multivessel disease is pretty robust now. There's been almost 5 studies, including complete, where have looked at, this debate of culprit versus complete. But in non-STEMI, there has not been a large randomized trial, looking at culprit versus complete strategy. However, Dr. Krishna Rathod from UK recently published an observational data of 38,000 non-STEMI patients in UK. They were collected between 2005 and 2015. Out of these 38,000, 22,000, almost 60% of patients had non-STEMI and multivessel disease. That tells you the size of the problem. It's a pretty significant issue. Now, these investigators evaluated a complete versus culprit-only strategy in these patients, and a primary outcome of this registry was all-cause mortality. And they published all-cause mortality at 4.1 year in this publication. And total of 11,737 patients in this large UK database underwent single-stage complete revascularization during admission for non-STEMI. The mortality, all-cause mortality, was 22.5% in the complete and 25.9% in culprit, which was highly statistically significant difference in favor of complete revascularization. So this observational study clearly suggests that multivessel disease PCI in patients with STEMI improved long-term mortality. So George, what do you do in your practice, and what have you been teaching your trainees regarding how to deal with non-STEMIs?
Well, I think that this was very helpful because I think we've too long really believed that non-STEMI was just a little heart attack. And I think people have forgotten that the substrate for non-STEMIs is often patients with actually worse disease than STEMI patients. They've had smaller infarcts and so forth along the way. They have more diffuse disease, and they generally have worse LV function at the start. They come in, they're not as explosive as a STEMI, so they kind of get passed off a little bit, and a lot of debate about what to do.
They're not that super sick.
That's right. And yet when you look at it, a quarter of patients who present with cardiogenic shock have non-STEMIs. So this is a serious population, and I think we haven't paid enough attention to it for a variety of reasons. I think it's the concept of the little MI, and it's really not a little MI. It's a serious problem. And so I believe the data that you presented and that was presented, it probably makes very good sense clinically.
Yeah. I think that, at least in our practice, both for STEMI and non-STEMI, what we do for patients, those who have multiple other vessels which are involved, is that usually we stage them. And we will do a physiology on all of these lesions, and we will only treat the lesions which are physiologically significant. That's at least strategy in our center. And that, I think, is very, very helpful, because then there's not a lot of question about which lesion to do, which lesion not to do. Physiology has already clarified everything for us. So that's the two really important publications this year. All right.
I think we've learned a lot this year about acute myocardial infarction.
There is no
actually,
doubt, yes.
Both STEMI and NSTEMI. It's been a good year.
Yeah, it's been a great year. Now, there's been a lot of controversy about left main, so let's talk about left main. Many of you have heard and followed recent controversy about long-term outcome findings from landmark Excel trial. So let me first discuss the 5-year follow-up of Excel trial, which was recently presented by Dr. Greg Stone at TCT. To remind everyone, Excel trial roughly enrolled 2,000 patients, approximately 950 patients in each left main PCI with Zion stent versus coronary artery bypass grafting arms. The patients had syntax score of less than 32, and they were deemed suitable by heart team to have either PCI or coronary artery bypass grafting. The primary endpoint was death, MI, and stroke for PCI versus CABG, and it was 15.4% for PCI and a 14.7% for CABG at 3 years. At 5 years, PCI was 22% and CABG was 19.2%, essentially unchanged and on the same trend as 3 years. Now, there are a few important points about Excel. 25% of patients had syntax score of more than 32 when core lab actually looked at the angiograms. Before, when the operators did it, they said the syntax was less than 32. When core lab actually evaluated the syntax, it was more than 32. So some very complex, CAD patient did slip into the study. He should have otherwise gone straight away to coronary artery bypass grafting. Second is 81% of patients had distal left main bifurcation stenosis, and that's important. And when we look at the results of PCI versus CABG, ischemia-driven target vessel revascularization was higher for PCI as expected, while stent thrombosis was lower, but the graft occlusion rate was higher for CABG. Also, atrial fibrillation and clinical depression were higher for CABG. So now let's turn to the controversy and the issues which are raised by Dr. David Taggart, a cardiac surgeon from UK, and has been widely discussed on many online platforms. He alleged that investigators downplayed the increased risk of all-cause mortality with PCI and oversold the reduced risk of study's primary endpoint of death, stroke, and myocardial infarction, particularly the benefit was because particularly the benefit for PCI was largely driven by high risk of periprocedural MIs with coronary artery bypass grafting. Now, while this debate is ongoing, a Nobel trial's 5-year follow-up was published in Lancet in December as well. Unlike Excel, Nobel's primary endpoint included non-procedural MI, all-cause mortality, repeat revascularization, and stroke. These MACE, MACCE, were higher for PCI, 28.4%, versus 19% for CABG. This was at 5 years. And the difference was driven mainly by new spontaneous myocardial infarction and repeat revascularization. However, Nobel also did not show difference in all-cause mortality between PCI and CABG, which is the issue that Dr. Taggart has been raising about Excel. However, it's important to note that neither of the two studies were really powered to measure all-cause mortality differences. So, George, investigators from the Excel have published, a very robust response to these allegations, and let's, take this apart piece by piece and discuss for our viewers.
Well, first of all-cause mortality, you need a large population to
Correct.
do that because there are so many confounders in there that include people who die of car accidents and suicide and just lots of things that are not related to the primary endpoint. So I think that's a little bit of a smokescreen in all of this data.
Yeah. We have to stick to the statistical clinical trial science. So that if the trial was not powered to look at all-cause mortality, that should not really sway our interpretation of the trial results.
We're really talking about the benefits of bypass surgery for people with left main disease.
Correct.
But the bigger issue has to do with what's an MI. And that's very difficult to compare surgery to angioplasty because acutely, it's apples and oranges in terms of kind of what the issues are. And so frequently small enzyme bumps that are seen with sensitive troponin measurements and so forth could be classified as an MI for PCI, and yet sequentially that has probably no impact long term. Bypass surgery, on the other hand, has all kinds of other reasons why markers are up, so they have a different level. And it was decided in this study, according to the investigators, that they would have a common definition, partly based on the fact that all the studies have shown that the higher levels of enzymes are the ones that really predict outcome long term. So what they did was they picked 10 times the upper limit of normal of CKMB and compared that between the two studies. And that's how they defined myocardial infarction. Now, the concern has been, well, what if they had used troponins? The universal definition uses EKG, but it's hard to get EKGs on patients post-bypass, so forth and so on, and troponins are very sensitive. They couldn't look at that because there were not enough troponins drawn in the study to actually do that. So we're left with data that has clearly shown the level of CK greater than 10 is what predicts mortality. So I think they did what was reasonable, and apparently everybody agreed on it at one point. So
yeah, the study is a study. Whatever the primary endpoint which was agreed upon at the start of the trial should be the way the trial should be looked at.
Apparently did not change the rules along the way.
Right. Now, in order to further dissect this, a Syntax 10-year data was also published recently. So to remind everyone about the Syntax trial, the Syntax enrolled 1,800 patients with left main and triple vessel disease and randomized these patients to either PCI or CABG. Couple things. The stent which was utilized in the Syntax was first generation, and the bypass surgery, whether it was on pump or off pump, was decided by a cardiac surgeon on site. Now, in this 10-year data, 94% of patients had follow-up. So that's a pretty incredibly good follow-up for a trial of this type. and a complete cohort of all PCI and CABG patients, there was no difference in all-cause mortality, which was another trial looking at all-cause mortality. Similarly, no difference in mortality was found in the left main cohort either, whether they had bypass or PCI. Medically treated diabetics had no difference in all-cause mortality. The patients who had syntax score of more than 33 or three-vessel disease did better with CABG. So what are your thoughts on how we relate syntax long-term data to this ongoing debate about left main and 3VD patients?
Well, I think the syntax is actually very reassuring. It does come back to what we've talked about, though, about completeness of revascularization. And in the earlier studies, 5 years and so forth in syntax, it was clear that PCI, where they had problems, where they had less complete revascularization. It seems to have averaged out over years, probably because there's been loss of bypass grafts over time. So those ultimately over long term become significant differences. But the syntax score greater than 33 is important. I think there's one other really important point to mention, and that is a separate study called Syntax 2. Syntax 2 really reassures us about the importance of identifying the significant lesion and only treating significant lesions and treating well with post-imaging, post-intravascular imaging. So in Syntax 2, they took patients that only had entry criteria but only got PCI. But they did FFR on almost all of them. They did post-evaluation of the lesions with intravascular imaging, did complete revascularization. Those people have had up to 2-year follow-up and have outcomes that are equivalent to the surgical outcomes in syntax.
Right. Now, but also in syntax 2, the syntax score was less than 32.
Right.
So we're talking about intermediate syntax score. So it seems like that both, Excel and Noble by today's standards really outdated trials, because, now if I wanted to design a new study with a left main and three-vessel disease, I would say, okay, we must have physiology guidance about which lesions we are going to treat, and we need to have a stent optimization by either OCT or IVUS. And the guideline-directed medical therapy is also substantially changed. We had PCSK9 inhibitors. We have, we're going to talk in a minute about REDUCE-IT trial. There are real significant advances in medical therapy that actually reduces spontaneous MIs in the future. That might actually change how we would evaluate these results in future.
And remember, the stents continue to get better.
Exactly.
And that, it's a moving target. And it's not that we're getting worse, we're getting better.
Right. No, I think that's very, very important. So I think that's, great discussion. So what do we learn? So our take-home messages from this debate are that left main disease patients with simple coexisting anatomy, which is syntax score of less than 32, when you talk to the patient in conjunction with your surgeon, PCI can be part of the consideration. This is a situation where physicians' clinical judgment of patient's surgical risk, along with informed decision of the patient, will be very, very important. A shared decision with the patient by taking into account all their social and their cultural beliefs, as well as taking into educating them on different possible outcomes is going to be very important. And the third message is that the guideline-directed medical therapy is extremely important, especially lipid and diabetes management in these patients.
I also think that the one thing that no one really likes to talk about but are important to talk about is the operator experience. And so some of these decisions are made because the operator may not be comfortable, and I think that's an important issue. The operator has to have the skill and the experience to do these.
And should feel comfortable about whether they can safely achieve that revascularization, because I think not having a complication is going to be very important, to produce the same result. Yeah. So let's now move on to some landmark studies revealed this year on medical therapy. So the first of which is going to be a trial called DAPA-HF, which is a use of dapagliflozin in patients with heart failure. Dapagliflozin is an SGLT2 inhibitor. Recently, several studies have shown improved cardiovascular outcomes in patients with diabetes taking this class of medications. Let us spend a few minutes in discussing SGLT2 inhibitors pharmacology. SGLT2, which stands for sodium glucose cotransporter 2 inhibitor, is a protein found in the proximal tubule of glomeruli. It is physically responsible for glucose reabsorption from the glomerular filtrate. The mechanism of this drug is totally independent of insulin. There has been 4 large trials involving more than 36,000 patients with type 2 diabetes and SGLT2 inhibitors treatment. These patients in 4 different studies experienced 25 to 35% lower risk of hospitalization of heart failure who were taking SGLT2 inhibitors. However, only 10 to 15% of these patients in these trials had a diagnosis of heart failure at the time of their enrollment. Hence, there was an interest in evaluating SGLT2 inhibitors in heart failure patients. DAPA-HF, which is dapagliflozin in heart failure trial, randomized almost 5,000 patients with ejection fraction of less than 40% and symptomatic heart failure. Patients with glomerular filtration rate, GFR of less than 30, systolic blood pressure of less than 95, and type 1 diabetes were excluded. They were treated with either DAPA, which is dapagliflozin, or placebo, in addition to standard guideline-directed heart failure therapy, and followed for approximately 18 months. The medical therapy was really good in this trial because 90% of patients were on ACE and ARB and beta blockers, and more than 70% patients were on spironolactone. Only 50% of these patients had diabetes at baseline, and more than 40% did not have ischemic heart disease. So it's very important that dapagliflozin, otherwise SGLT2 inhibitor, which is a drug for type 2 diabetes, were really used in patients with heart failure, whether they have diabetes or not. So what are the results? DAPA compared to standard heart failure therapy and placebo reduced the combined risk of cardiovascular death, heart failure hospitalization, or urgent visit for worsening heart failure. Moreover, it reduced cardiovascular death by 18% and all-cause mortality by 17%, regardless of their diabetic status. These benefits were in both groups. So what may be the mechanism of action of this drug? One hypothesis is the natriuretic effect of dapagliflozin. The dosage, however, of diuretic was not changed by addition of DAPA in the study. So it does have natriuretic effect, but if somebody was on 40 of Lasix BID and you add DAPA, you don't need to change the diuretics because the effect was present even in patients, those who are on loop diuretics, who the loop diuretic was already keeping their pro-BNP of less than 1,500. And DAPA only changed pro-BNP by 10 to 15%. So there was only 10 to 15% decline in pro-BNP. So it appears that the mechanism of action is independent of natriuresis. So there are other hypotheses as well. However, they are not well understood. In addition to DAPA heart failure main findings, there was an important sub-study presented to evaluate the safety and efficacy in different age group of patients. Most importantly, there were no safety issues found in the elderly population of patients, and the drug was effective in all different age group of patients. So the take-home messages from the DAPA heart failure trial are dapagliflozin reduces heart failure admissions, urgent visits for worsening heart failure requiring diuretics, and cardiovascular death in patients with and without diabetes. So George, that's just really an incredible trial. A completely new class of drugs, now, being given to patients who have EF of less than 40% and a symptomatic heart failure and on a good medical therapy, and adding this drug still reduced almost 17% cardiovascular death, and all other secondary things that you can think of, readmissions, et cetera. So as a cardiologist, you're going to start prescribing SGLT2 inhibitors?
I think cardiologists are going to have to. I think it really makes one important point that's been said, and we've touched on it over the years, back and forth, but cardiologists really need to understand diabetes and diabetes medications.
Right. Because
so much of what we do is interacting with diabetic patients, and it's so critical in outcomes. So, yes, I think these studies are going to be sliced and diced, and there are going to be other studies looking at this. But at the moment, I think cardiologists really have a responsibility to learn this and use this in their practice appropriately.
Yeah. Not only that, that this was actually done in patients with the LV dysfunction, but drugs are being investigated now for preserved heart failure, preserved ejection fraction.
Right.
These drugs are also being looked at in patients with peripheral arterial disease in these big trials. So really, SGLT2 inhibitors are really going to become a drug that's going to be prescribed more and more by cardiologists, at least in our practice. We've been very resistant about it because it's been talked about for the last couple of years, but now we are, prescribing SGLT2 inhibitors to several of our patients, and I think that we're going to continue to do more and more of this.
We have to understand diabetes, and we have to treat diabetes.
Yeah, it's very, very important. Another pharmacology trial called REDUCE-IT evaluated icosapent ethyl. The purpose of the study was to evaluate whether this drug, combined with statin therapy, will be superior to statin alone when used as a prevention in reducing long-term cardiovascular events in high-risk patients with mixed dyslipidemia. To remind viewers, the REDUCE-IT trial enrolled 8,000 patients with a baseline triglyceride of more than 150, which was later changed to more than 200, and LDL of more than 40 but less than 100. They must have heart disease. Median triglyceride in the study was 216, and median LDL value in the trial was 75. Here are the results. The median triglyceride decrease was 18.3% in the Vascepa group. LDL increased in the entire study population. However, it was 6.6% lower in the Vascepa arm than in the placebo arm. There were a total of 1,606 participants who experienced clinical events in the study. The primary endpoint was composite of cardiovascular death, MI, stroke, coronary revascularization, or admission for unstable angina. Approximately 17.2% of participants in the Vascepa group versus 22.2% in the control arm experienced primary endpoint, and between the group difference was 4.8%. The confidence intervals suggested a treatment effect, and p-value was less than 0.001, a highly statistically significant finding in favor of Vascepa in the study. It was interesting when the investigators claimed that there was no influence of baseline triglyceride level, whether less than 150 or more than 150 on primary or secondary outcome. The reason being is that very few patients were enrolled with triglyceride of less than 150 in the study. Secondly, there was a large amount of mineral oil given in the placebo arm, which may have influenced the absorption of statin in the control arm. It is unclear whether this could have widened the effect differences between the two groups. However, in summary, this was a very highly successful trial, and the take-home message here is icosapent ethyl or Vascepa 2 gram twice daily reduced triglyceride, reduced cardiovascular events and cardiovascular death among patients with known cardiovascular disease or those at high risk of developing it, and they are already on optimal statin therapy with relatively well-controlled LDL levels. Vascepa also reduced the rate of MIs and revascularization, but in the trial, the Vascepa group did have higher bleeding risk, higher risk of edema, atrial fibrillation, flutter, and constipation. This is one of the first non-LDL targeted trials to show cardiovascular benefit and will likely be featured in the American guidelines. So George, we were just debating PCI versus CABG, and we noticed that the PCI does not confer protection against a recurrent MI. And this is one of the big issues, right? When we compare with PCI CABG in a very long run. So now you looked at the reduced set, and I just showed you that icosapent ethyl reduced significant number of recurrent MIs. And we have also seen this in PCSK9 outcome trials, Fourier as well as Odyssey, that these drugs have reduced recurrent MI. And I also just showed you SGLT2 data, which also reduced MI events. So would you be prescribing Vascepa to almost all of your cardiovascular patients now?
Well, I think this just really emphasizes how important it is that we treat as effectively as we can, both with diet and with drugs. And this idea of combination therapy is really important because you're limited in any one drug as to how far you can go. And this is an additive effect. Plus, triglycerides have always been a concern, but no one's really been able to effectively treat them. I think that's one of the secrets to this drug. It's been very effective. And I think it illustrates that we still have a ways to go, and adding other drugs will likely make a big difference in terms of reducing events. I particularly think the idea of early treatment around infarct will be very important, because that's probably where the action really is.
Right. So you feel that, I know there's a small study that's ongoing now, or may even be completed, where they're giving PCSK9 inhibitor at the time of PCI for acute MI.
Right.
And it's been shown in the statin trials, of course, before that,
Right.
we do make a difference by reducing inflammation. So I think that future trials will guide us even more, and that whether acutely we need to be so aggressive and even in the late follow-up. But I do think that the goalpost for what a real true optimal medical therapy for these patients is really changed a lot. And I think that if we take into account all the results of the PCI versus CABG trials, and when you start forcing ourselves to do a optimal medical therapy, you realize that we're going to actually now producing outcomes which are, if not the same as CABG, but may even be better, because we might reduce the progression of the disease.
Right, and I think this is critical. It's fascinating. We still don't know what the right cholesterol level is and the right triglyceride level. I'm convinced that we don't know that magic number. And it started out in my career, the normal cholesterol was the standard for the population, which was way too high. And some of these other numbers have been somewhat arbitrary, and I think this is an example of where we're honing that information.